All right, are you guys ready?
Yeah, let's get started.
Should we start?
Sure.
We have 170. Oh, the participants are increasing rapidly. So good morning, everybody. Thank you guys all for being here. So we're really lucky today to be able to do this as a group and to have anesthesia, general surgery, neurosurgery, orthopedics all together to hear the same message from two folks. I'm going to introduce José Rodriguez, who's currently our Associate Vice President for Health, Equity, Diversity, and Inclusion, and Maia Hightower. But before we begin with our grand rounds on overcoming sexism and racism at the U of U and next steps forward, Dr. Mark Harris, who is our CMO for GME, has another message about a sort of a forward-thinking diversity project for the University of Utah called the Concept Community Program that he'd like to introduce, and then we'll get on with the main part of Grand Rounds. And just so everybody knows, people are muted because this is such a big group. But if you have questions, which hopefully we'll have time for at the end, please send them into the chat. And Jeremy Alt, who's Vice Chair of Equity, Diversity, and Inclusion for the Surgery Department, and I would be happy to field those at the end to Dr. Hightower and Dr. Rodriguez. All right, thanks. Go ahead, Dr. Harris.
Well, good morning, everybody, and thank you for this, letting me elbow my way into this wonderful grand rounds. I want to talk a little bit about Concept to Community, which is a program that the rural portion of my office is setting up or has set up. It's basically, we have mercilessly and shamelessly stolen the idea of bench to bedside and changed it to Concept to Community. And it's really the same idea, but it's not gadget oriented. It's not device oriented. It is program oriented. The idea is that our GME trainees, coupled with other trainees, other students, other practitioners, would develop some kind of program in partnership with our rural partners that addresses needs in their community. Whether that ranges from increasing awareness of a particular issue, whether it's educating the public and public health issues, whether it is setting up a different kind of neonatal monitoring program for people in the, whatever it is, whatever the idea that you happen to have as a trainee, partnered with our rural folks or even with other students, we want to hear about it. Basically, we want you to submit a couple of page proposal by May 15th, focusing on what you're doing. There's a pretty easy form for you to fill out, and we will give you anywhere from $500 to $5,000 if we think it's a worthwhile program to realize what you're trying to do. We are, as I say, partnering with our rural folks. We've got a kind of a menu item of things that they're interested in having people work on, or you can come up with something yourself. Us and our rural partners will kind of judge the submissions and throw the money around as we see fit. There's a link there at the bottom. I don't expect you to write it down. I'm happy to share this slide deck. I'm happy to share a brief little flyer that has the information on it. If you want to reach out to me, I think everybody on this call probably knows who I am and can find my email address. And that is basically my pitch. Any quick questions before we get to the important stuff? Or if you do, feel free to email me, call me, text me, ping me, any way you want to get in touch with me. I'm happy to answer questions about this. You've got another couple of weeks to submit, and we welcome, the only really requirements are that you have to be a GME trainee and that this has to be rural and in Utah. And that is it. Dr. Carol, I throw it back to you, sis.
Thanks, thank you. All right, so again, I'm so honored to be able to work on this EDI momentum that's going forward in our university, and so proud of it. And Jeremy Alt and I were talking about doing a grand rounds, and it just blossomed into this wonderful thing to have all these departments hearing the same message at the same time. And our real hope, of course, is that this is going to generate discussion and thoughtfulness amongst all of us who get to work together so often. So Dr. Rodriguez, I'm going to send it to you so you can introduce Dr. Hightower.
Outstanding. Thank you very much, Dr. Carroll. I think we'll start off with our PowerPoint. I am delighted to be here with all of these, with a large number of departments, surgical departments and anesthesia departments. I'm very, very fortunate to have been able to meet a lot of you in this position. And I am heartened and excited by the ownership that your departments are taking in the space of equity, diversity, and inclusion. So today's talk is about dismantling racism and sexism. I'm going to start off by introducing Dr. Hightower. Dr. Hightower is our Chief Medical Information Officer, and she came to us from Iowa, where she was also a Chief Medical Information Officer and a Chief Officer of Population Health. Dr. Hightower has a long pedigree of outstanding institutions, so I'm going to read them all. She's been to Stanford, went to Rochester for medicine, went to UCSD for her residency in medicine and pediatrics, and she has an MBA from the Wharton School, which I had to look up, was the University of Pennsylvania. And we have been blessed by her presence ever since she got here. And in February of 2021, she joined our office as the Senior Director of Equity, Diversity, and Inclusion. Now, I'm going to tell y'all this, but I'm not supposed to say it out loud. She's the Senior Director of Equity, Diversity, and Inclusion is really the equivalent of an Assistant Vice President title, but I'm not allowed to give those out because it's moratorium by legislature. But we're delighted that she's joined us. She's with us on a part-time basis. And in the short time she's been with our office, she has transformed how we think. So let's go to the next slide. There we are. And this is our team. In the end of 2019, this slide would have had only 5 people on it, and 4 of them would have been staff members in my office. However, in the last year, this office has exploded. As you can see, we have Dr. Hightower, who is our Senior Director, Health, Equity, Diversity, and Inclusion. We have our co-directors of WIMS, who now report to our office. And WIMS is Women in Health, Medicine, and Science. And that organization is really the one charged with leading our anti-sexism efforts. We also have 3 employees in our office, 3 managers. You can tell that there's not an administrative assistant on there, and that's because she starts today. And her name is Loretta, and we're delighted that she's going to be on our team. You can also see that there's a lot of dotted lines here, and these dotted lines are all about collaboration. So we have a Senior Director of Health Equity at the hospital. We have the School of Medicine Health Equity, Diversity, and Inclusion Office, and that's an Associate Dean's office, and that's run by Dr. Cariello, and the Assistant Dean there is Dr. Kimiyu. We have Associate Deans announced in 2 different colleges and health sciences, the College of Nursing and College of Health. I was informed yesterday that the School of Dentistry will be doing the same thing. And then we have our collaborators at Huntsman Cancer Institute. This is an interesting relationship because Dr. Okuyemi is my chair, so is my boss. However, in this role, I'm his boss. So it's a wonderful thing that's happening there. Next slide. So our office is a consultative service, and we assist the individual departments and help make their equity, diversity, and inclusion goals, help them make and meet their equity, diversity, and inclusion goals. Now, we assist the departments in our role as helping in the School of Medicine Health, Equity, Diversity, and Inclusion Office, and we assist the colleges in our role as the Health Sciences Health, Equity, Diversity, and Inclusion Office. We define the focus for EDI efforts. We coordinate the efforts, ensuring harmony with main campus. We set accountability metrics, and we do what we do today, which is give presentations. Next slide. So our shared vision is that here in health sciences, we will research, challenge, and eradicate systemic sexism, racism, and bias, and the resultant health disparities. And so we will work with our partners in this room to support and develop institutional actions, policies, and funding mechanisms to really ensure that health equity, diversity, and inclusion become the forefront of our thought processes. We have here listed our focus on historically marginalized groups. It's important that we recognize that not all of them are mentioned in this slide, but the School of Medicine and health sciences in general has decided to focus on the historically marginalized groups that are at the beginning here, which are Black or African American population, American Indian, Alaska Native population, Native Hawaiian or Pacific Islander population, the Latinx, Hispanic or Latino population, Southeast Asian population, LGBTQ plus community, and women. That's focus. That doesn't mean that we don't care about the other groups. And we want to be the campus of choice for people's learning and employment. Next slide. So So I'm going to invite you today to come with Dr. Hightower and I to the growing edge of our learning. So it turns out that when we learn, we like to learn in our comfort zone. But I'm going to invite you to become uncomfortable today, because it is where we are uncomfortable where learning happens. And I'm also going to invite you to have an open mind and challenge your ideas and my ideas of what fairness really means. Because today we're going to talk about equity and how it can be advanced. Main campus, Dr. Villarreal, her main idea here is to help us center equity in our equity, diversity, and inclusion work. And now we will go and hear from Dr. Hightower, who has the bulk of this presentation. All yours, Maia.
Hello, everybody. Thank you so much for having me today. You guys are the lucky recipients of the first version of this presentation. I'm actually invited to present as well at Intermountain Healthcare's grand rounds for their surgical department as well. So if you happen to have a co-appointment and you're also attending Intermountain's grand rounds, I'll see you next week. So I'll be talking about the role of healthcare IT more as an example on how we can address systemic racism and bias as a strategy for our patients and the workplace. And really, it's really about the moral imperative of addressing systemic racism and bias in healthcare and in the workplace. And so we have a unique opportunity, because not only do we have the privilege of addressing systemic racism and bias for our patients, but we also want to create this amazing workplace to ensure that the differences that we have are celebrated. The diversity of thought, the diversity of experience, the diversity of our stories are shared in an inclusive and authentic way. So we know that systemic racism is a public health crisis. Our health system, as well as the 4 health systems, major health systems here in the state of Utah, have publicly declared systemic racism as a public health crisis. When it comes to COVID-19, that really was a wake-up call for so many, not necessarily for Jose and I, but it was a wake-up call in that we recognized that there was the dual pandemic of both systemic racism and COVID-19. With COVID-19, Black patients, Black communities are twice as likely to be infected and 3 times as likely to end up in the hospital. And the same is true, or die, and that is the same is true of our Latinx community. We also faced this summer the wake-up call of racial injustice when it with the murder of George Floyd. And really that those two events together have created a whole lot of momentum around addressing this age-old problem, as old as man, as old as definitely in the United States, over 400 or 500 years old, of systemic racism, and then of course systemic gender bias, even longer, or just as long. So we're so proud of our University of Utah Health team. Our team really has come together to recognize this challenge in a new way, with new momentum. And many of you may have been present this very day as we sat in silence in recognition of the work to come. So again, I'm going to be using our healthcare IT systems as an example. And it's really just an example of how we can address systemic racism and bias within an organization structure that isn't traditionally seen as the forefront of addressing systemic racism and bias. But that really is the whole point, is that systemic racism and systemic bias are hardwired in our processes. In healthcare IT, they're hardwired in our IT processes. They're actually coded into our IT systems. And when we think about, say, surgery or our care delivery mechanisms, the way that we provide care, it is equally hardwired in the way that we deliver care. So when it comes to healthcare IT, we specifically have the challenge of digital redlining, which is the practice of creating and perpetuating inequities between already marginalized groups, specifically through the use of digital technologies. And we've seen this, whether it's education in Zoom in the last year, where a disproportionate children of marginalized communities have been left behind. We've seen this in telehealth. We've actually looked at our own telehealth data, and telehealth was so critical in maintaining access to care for our patients during COVID-19. And yet the adoption, if we just look at access, a 3-point difference between our Latinx community and our Caucasian communities in accessing our digital tools. So it's not just about accessing digital tools. In healthcare IT, we also have to address systemic bias that is hardwired in our algorithms, hardwired in how we use our systems to differentiate or provide scarce resources to our populations. This is an example of a racial bias in a health algorithm. This health algorithm was specifically a population health algorithm. And essentially, this algorithm reduced the number of Black patients identified for extra care by more than half. And the bias occurred because of a labeling bias. So the labeling bias used health costs as a proxy for health needs, even though we know that Black patients have a lower spend than white patients for a large variety of reasons. And yet that was used as the label to correlate with risk. So this particular example decreased the amount of resources to patients, to our Black communities, until it was identified and subsequently modified. But we have to be very careful not only of our AI algorithms, but as well our algorithms that we've long used within healthcare. So systemic bias, that was just an example. Systemic bias in healthcare is a really complex problem. So how do we go about addressing it? Where do we start? Is it analysis paralysis, or do we just dive right in? So in the CMIO division, we've developed a strategy. And again, this is an example of how an organization or a system can start addressing diversity, equity, and inclusion in a systematic way. So we developed this strategy, and I call it the Healthcare IT Equity Maturity Model. You don't have to memorize the model, just know that there's a lot of different areas where one can start. And on the left-hand side is starting with leadership and vision. Many of our organizations, many of our teams have already done that. There's a whole other component around managing the IT function that is specific to IT. And then there's developing this inclusive culture as well as retention, recruitment, retention, and development of our teams. So here in the healthcare, in the CMIO division, we've identified 7 different initiatives to take on. I won't go through every single one, but we'll start with what we did with our vision statement. This one is very simple, right? And I think so many of you have actually already updated your vision statements to include equity as part of your vision. And so that's the first step that we did, is we changed our vision statement to include, we contribute to the exceptional and equitable patient, faculty, staff, and learner experience. And we also embrace an inclusive culture that drives innovation, ensuring that we have a place of psychological safety so that we can leverage the diversity of thought, the diversity of experience in order to drive innovation. So in the CMIO division strategy, many of you have been privy to the strategy, bits and pieces of the strategy, specifically around, say, virtual care or the way that we use data and the access to data. Separate, included in the overarching strategy is the healthcare IT diversity, equity, and inclusion strategy. And so these are all of the different specific initiatives that create a roadmap from that overarching model. So within healthcare IT, there is that leadership and strategy, as I mentioned, as well as addressing health equity for our patients, as well as creating inclusive workplaces where our diversity and a place of workplace belonging can really drive an inclusive culture. So I'll talk first about the patient focus, how we address disparities using data. In the first thing that we are doing as a system, and this is really at a systems level and available at a department and division level, is ensuring that we have the tools to measure. So our team has set about, in partnership with our quality department as well as with patient experience, to develop a health equity measurement framework and dashboards to measure inequity and outcomes, whether that's outcomes in quality measures, outcomes in patient experience, as well as disparities in outcomes in digital access. So these tools will be available to you as well, to your surgical departments, when you think about the surgical quality measures or process measures that you'd want to measure, because we've made it in such a way that it is centralized within the data warehouse, and any sort of quality measure, any metric can be seen from an equity lens. I'll give an example. Our first use case really at slicing our data differently. Being able to see the disparities in care was our patient COVID-19 vaccine distribution effort. And as you can see here, when on the left is race, ethnicity, so our demographic data. And over on the right, percent scheduled versus invited. In blue is when a population is overrepresented. And then in orange is when, in that bar chart, when a population is underrepresented. So the underrepresented, it's very clear where there's disparity as well as where there's opportunity. And you can see that there's both disparity and opportunity to do better in our Latinx population as well as our Black and African American population. One thing that is apparent as well is the unknown or declined. And turns out when we look at who are the unknown, when our data quality is poor, they're actually our most disadvantaged populations. They live in zip codes, and we actually did a zip code analysis. They live in our most vulnerable zip codes. And so even if the data shows, oh, our Latinx population is doing better, or we've closed the gap on our for our Black patients, unless you address the disparities in the unknown, then you still have a problem. So we recognizing, learning from that experience, we actually have developed a project to improve our demographic data gaps. So for our patients, we're actually kicking off a pretty big project with care navigation in evaluating how we collect patient demographic data and in improving this process. And then for employees, you may have received a request to update your demographic data. And that's actually really important when we're measuring our workplace belonging and inclusion efforts. And we use that data in the data warehouse, same methodology, and we have the same data gaps for our employees. I checked my own race ethnicity data, and it was marked as unknown, and I never in my life have marked my race as unknown. I'm quite aware of what my race is. So I definitely recommend everyone to take a look at what is being presented as your race in our HR system. So that's what we're doing when it comes to measuring disparities. I think it's very important that we address racial bias in clinical algorithms and making sure that bias in algorithms is visible. This is a great, another sort of wake-up call article in the New England Journal of Medicine, August of last year, Hidden in Plain Sight, Reconsidering the Use of Race Correction in Clinical Algorithms. And they do a systematic review of a number of algorithms that use race. And many of these algorithms, when you add race, specifically Black race or non-white race, the risk associated with that outcome is increased and often guides clinicians to decrease care or defer intervention. One example is the American Heart Association Get With the Heart guidelines. I'll talk a little bit about that, as well as things like the cardiothoracic surgery short-term risk calculator. As an institution, we have recognized with our clinical decision support committee that race may be a proxy for unmeasured factors and it may have unintended negative consequences. So as a system, our clinical decision support committee is reviewing all of our content and making sure that we evaluate race and gender, the use of race and gender within our clinical decision support systems. So this is again an example from the American Heart Association Get With the Guidelines. In the Get With the Guidelines heart failure risk score, the addition of race, specifically Black race, increases risk. And because it increases risk according to the calculator, it increases risk of all-cause heart failure mortality. It decreases a referral rate to cardiology. So that would be the recommendation from the calculator. Our partnership, we actually are the implementing partners for MDCalc. The University of Utah, specifically Ken Kawamoto's team, does the integration between the MDCalc to Epic, not only for the University of Utah, but actually for all Epic integration. And they've worked with MDCalc to make it clear when race is being used in a calculator so that you can use your clinical judgment. They've changed the default setting so that race is not automatically pulled into the calculator, but alerts the clinician to when race it can be an input and may have unintended consequences. And then they also have a link to their statement. So next steps for us. So as an institution, we address bias in our statistical algorithms. Our next steps really are developing a framework for algorithmic bias and fair AI. So there's two different aspects of algorithmic bias and fairness. So algorithmic bias is how the data is modeled. There are many ways that bias can be introduced. For example, the labeling bias that occurred with the United Healthcare algorithm, the population health algorithm, to sampling biases that occur from underrepresentation. There's a lot of different steps where bias can be introduced. And then there is the concept of fairness, and how do we ensure that the output is actually fair and achieving the goals that we want to achieve. So that's what we're doing for patients. And again, there are many things that you can do for patients, whether it's recognizing bias in algorithms, measuring what is important for your work, your department's divisions, and ensuring that you have an equity lens so that you can measure disparities, as well as start thinking about interventions to develop to address those disparities. Our workplace focus, now shifting to a workplace focus, we really want to create a culture of diversity and inclusion where there's psychological safety and we're able to come to work bringing our authentic selves to work so that we can learn together, grow together, and innovate together using the talents that our people bring every day. In similar framework, we are developing staff equity key performance indicators so that we have the data in order to measure inequities in our career pathways, from recruitment, retention, career development, all the way to leadership representation. Now, your department's divisions have the beginnings of that type of data, specifically looking at demographic data. And we've, here at the University of Utah, been one of the innovators actually in this space in measuring pay inequity by gender. And so that has been going on for quite some time at a department and division level. This is a team of women that have been working on the equity dashboard. These 9 women are all within my CMIO teams. They comprise end-to-end data solutions from data architects, data engineers, data scientists, as well as provider informaticists. And they really kicked off this deeper dive into equity metrics and how we organize the data in order to provide that insights into the longitudinal experience of our employees in the workplace. So lastly, I'll end on a culture of inclusion and how we can connect with community through our team members. So our team members in the CMIO division actually have a merit goal that focuses on developing a culture of inclusion and connection to the community that we serve. We recognize that, especially amongst our IT and data teams, that we are the stewards of the data. We are the stewards for all of our healthcare, for all of our communities in the state of Utah, that we want to ensure that the value of healthcare IT, the value of digital transformation is shared equitably across all of Utah, all of the communities that we serve. And so in order to continue to develop inclusion within our community, as well as develop cultural sensitivity, our merit goal really has spanned over the year a continuous learning process. It's point-based, I won't go too much into it, but lots of opportunity for our team members to explore identity, to explore how the work we do can either increase disparities or decrease disparities. But if we do nothing, the disparities will only increase. But if we do something, if we are anti-racist, anti-biased, then that is how we intentionally close the gap and really can ensure that data, analytics, IT, our efforts are novel approaches to eliminating disparities. So these are some of the examples of projects that my team members have done, whether it's working on the equity dashboard or addressing race bias in clinical decision support, to things like Innovation Day. We've all participated in the Harvard Implicit Bias Self-Reflection, participated in a lot of guest speaker events, just like you are today. So simple things that have been included in our team's approach has been the Harvard Implicit Project Implicit. It's a simple, easy tool test to start an internal conversation, internal awareness about implicit bias. But it doesn't end there. And many of us have also participated in self-reflection and discussion. This is an example of one of our discussion speakers, Dr. Teresa Martinez, one of our faculty members at the School of Psychology. And she provided information, just plain information about the demographics of Utah. I think most of us sometimes lose sight of the people that we serve, and when the people that we see in our clinics may look different than the census data for the state of Utah. We've also explored, again, within healthcare IT, things like, is code colorblind? Well, code is not colorblind. Taking advantage of the resources from the university again. Main campus had a wonderful speaker, Ruja Benjamin, talk about, she is the founder of Princeton University's Just Data Lab, and looking at the social dimensions of race and technology, medicine, and how bias has been hardwired into our IT systems. If you would like to explore bias and algorithms further, which I highly recommend, Weapons of Math Destruction as a book, and then Coded Bias. So this was a Sundance Film Festival selection last year. It is now available on Netflix. It's a interesting look at, again, how bias is coded, hardwired, not only in our healthcare systems, but of course our financial systems, our HR systems, our facial recognition and justice systems. So very eye-opening as well. So what can you do to address structural racism and bias? Well, I mean, again, I'm an IT person, so I'm going to focus on IT today. But being aware of bias and algorithms is probably one of the key takeaways. When IT systems present you with clinical decision support, and if race and gender is part of those algorithms, be wary and ask those questions. Does the use of race and gender limit allocation of resources? And if so, is it clinically appropriate? You know, you can uncheck that box for our straightforward statistical algorithms. You can uncheck that box if it's not relevant, if it's being used as a proxy for other social determinants of health. And then for our AI algorithms, you know, really being wary of those AI algorithms as well. And then measurement, measure, because tangible goals make ambitions real. Only when we were able to measure disparities in our COVID-19 vaccine distribution efforts, we're able to have very targeted interventions to try to eliminate those disparities. And that's the same whether it's measuring workplace disparities or health equity disparities. And then cultivating a culture of inclusion and belonging. And that is a journey. It's not a one and done. It's not, you know, listening to this conversation today and poof, we have a culture of inclusion. As you all know from surgery, developing psychological safety in a place where you can pull the line, even if you're the M8 or the tech in the room, it is a culture shift that takes time, it takes effort, and it takes leadership at all levels, from your most senior leaders all the way to our middle leaders, and empowering our everyday workforce. So that is, now I transition to Jose.
Thank you, Dr. Hightower. As I was listening to your talk, I was seeing, you know, the whole My Chart thing in Spanish. And I think of what a boon that would be for my patients that are, I think 85% of them are Spanish only. And then I thought about something that's far more selfish, and that is that My Chart utilization actually affects who fills out the EPE scores. And so one of the things that we're noticing is that the absence of that actually affects our faculty of color because they can't get scores from their patients. So I'm delighted about this work that you're doing. And I will tell you that I'm very, very excited that we're actually looking at this straight on. All right, we're taking it on. And we've talked a lot about racial bias in the healthcare IT. And I think the reason we use that one is to show that it's everywhere. But we don't show that it's everywhere only in racial bias, but there's also sexism everywhere. This slide is a little controversial because it says 4 kinds of menfolk, but it talks about sexism in general. And when we're talking about sexism in general, we're talking about anti-woman sexism. And, you know, it talks about a continuum here where there's active sexists and there's anti-sexists. Obviously, we want to get to this anti-sexist space. And this is one way to do it is actually to really challenge anything that looks and feels and sounds sexist. And this example uses jokes. But honestly, we need to look around at our leadership tables. And when we look around at our leadership tables, we need to think about talent, and we need to think about perspective, and we need to think about who's not represented. And I think once we start making those changes, I think we will start moving towards elimination of sexism. Let's go to that next slide. Now, this over here is actually the same thing, but it is about racism. And it talks about institutions being exclusive and institutions being fully equitable, diverse, and inclusive. Now, I think that if we were to look at the columns, there's a lot of information here, but there are things that our institution does that really does make us seem like an exclusive institution, and some things that our institution does that makes it look like we're a passive institution. And there are some things that we're doing that we're in identity change. But the idea is to move to fully equitable. I've never worked at a fully equitable, diverse, and inclusive organization, but I actually believe that this one can become one. Next slide. So department leaders, when we're talking about what can be done about this is outside of the IT space. However, it needs to be done as well. And that is, we need to really examine our leadership for diversity at the department level, focusing on race, ethnicity, and gender. Look around the table and seek the perspectives that are missing. One of the things that we're looking at right now is that we are an excellent institution. All right. Now, how do we get from being excellent to being preeminent, outstanding, to leading in medicine? I think one of the things that we need to do is focus on equity and make it central to our decision making. And we have to examine our policies. I think our department leaders can lead the anti-racist and anti-sexism efforts. This is probably the most important point on this slide. And that is that when we're talking about equity, diversity, and inclusion, anti-sexism, anti-racism, we know that equity, diversity, and inclusion leaders who are titled have a job in coordinating that work. But those whose titles are department chair, vice chair, division chief, they're the ones that really need to do the work, and we are here to assist them. And we invite you to lead in that effort, and we invite you to engage with Dr. Cariello's office at the School of Medicine and with our office at Health Sciences. Next slide. So this right here is a link to the NIH Diversity Protocol. We're not going to go through it. It is very involved. However, this is a method that Dr. Valentine actually put together while she was the Chief Diversity Officer at NIH to identify diverse talent using PubMed. So using the indexes of our scholarship. I like this protocol. It is extremely involved. And so when you do go to this link, I'm going to ask that you do two things. One is don't get overwhelmed because it's a hell of a lot of work. And two, think about inviting our colleagues in the library to help, because essentially what it is going through the literature, identifying who the scholars are in certain areas, and then going and finding out what those scholars do, what their backgrounds are, where they are, and then creating a catalog so that when openings come up, we can actually look we can actually look in our catalog and start making individual outreach. What's interesting in faculty diversity is that faculty diversity is dependent on individual outreach. Placing ads will never get diversity. I can't think of anyone that I know who's an underrepresented in medicine faculty member that's ever responded to an ad. It's all been personal outreach. And I'm one of those. Next slide. So these are 3 papers that talk about things that we can do. One of them is called Abolish the Minority Women Tax. And this has to do with the fact that women in institutions across the country actually have more citizenship duties in departments than men do. And as you know, citizenship duties are not reimbursed as the same as clinical duties, so it translates to a pay disparity. Many women feel that they're invisible in their departments, and this is actually amplified in women who are from underrepresented backgrounds. And so it's an invisibility tax. Also, the paper actually encourages us to reward the extra labor of underrepresented minority women because it substitutes the work of everybody else. And it also says to intentionally make space for underrepresented minority women to share their expertise in areas of influence. So these are 4 things that we can do as we move forward in this effort. Identify who these people are and work on making it so that this talent pool has a strong voice in our institution. It can only make us better. Next slide. This is another paper called Dear White People that talks about things that we can do as institutions and individuals to actually work on our bias that's systemic and our bias that's individual. I think it's important to say here is that we're not talking about the racism that comes from, you know, self-declared bigots. We're talking about the racism that exists in the absence of racists. One of the things that the authors invite people to do is that we learn about the roots of systemic racism and institutionalized racism, both in the history of this country and in medicine. And that once we learn, we act to undo the things that have been going on really in all of our lifetimes. Next slide. This last slide talks about what we can do as a predominantly white institution to actually use the power of white privilege to actually cause change. And one of the things that we can do is actually view race, ethnicity, diversity as an essential asset to the institution that improves teaching, scholarship, and health outcomes. In the past, we've seen it as a bonus, and now we got to see it as a needed thing. Next slide. These are other resources that you can use in your equity assessments, and we will help with all of these. Just give us a call and we'll be with you on it. And I think the last slide is next. Good, we got it out. We got 10 minutes for questions. Thank you all for being here. I can actually see the chat. So if you want to put them in the chat, we can do it that way. Dr. Carroll, is that how we would like to do the questions?
I think that's the way we have to do the questions because it's such a big group. So that would be great. So if folks can please put questions forward, that'd be terrific.
We will also take comments. Okay, it says here, thank you for operationalizing inclusion in addition to equity and diversity. This goes to the quote by Verna Myers, diversity is in being invited to the party and inclusion is being asked to dance. And you know, you're absolutely right on that. It's more than just being present. It's feeling like you belong. And I think that as we center equity, we will see that belonging will be part of it. It says here, we've talked a lot about recruitment. Can you comment on actions for retention? What a great comment. So there's a few things that have to be done in this space. And one of them is that we're talking about underrepresented minority faculty and women, all right, of all races and ethnicities. I think this is a talent pool that is going to be high risk for being poached, all right? Other people are going to be like, we want you, we want you, we want you. And so our job here is to be actually proactive in our retention efforts. That means that we have our eyes open for when people are going to get promoted or going up for promotion. So especially those in the tenure line. I mean, the tenure line thing is you go up or you go out. And so we have to have retention packages that are ready and in our back pockets for when people go up for promotion so that we don't lose them.
Yep, and I will also add that we have a lot of data on the experience of our team members. And we need to use that data in order to improve the experience, to ensure that the experience in the workplace really is equitable. Right now it's not, and if we look even at our Waggle data for our faculty, which is our sort of our engagement, how we measure engagement, there are disparities in experience. We can't let the law of small numbers negate the experiences of small numbers. If anything, because our numbers are small, it warrants further investigation when there is a signal. And so I would just implore from a department and division perspective, you may see, oh, we're doing so great when it comes to our provider experience or our staff experience. But until you actually look at the small numbers, that message, that disparity in experience gets obscured in the wider number.
What a great comment. You know, it's so important that we address the small numbers in two ways, right? One is to address their concerns, and the other thing is to figure out why it is that the numbers are small. Actually, it doesn't matter why the numbers are small. We need to change that. And that we invite our leaders in this call to do that, and we can. It says here, how do surgical residencies and fellowship increase recruitment of diverse residents and fellow in an era of Zoom interviews and limited away rotations? Having current diverse residents and fellows reach out specifically to female and minority applicants, other appropriate strategies? You know, I think I'm gonna punt. Mark has been working on this. Mark, maybe you could talk about some of the successes you've had in the GME space in actually, and some of your program directors in recruiting diverse residents, what they've done.
Yeah, thanks for that question, Lucas, because I think this is important and it actually speaks a little bit to both recruitment and retention at all levels in healthcare. If you've got a diverse group of residents, then med students are more happy to come here, and diverse faculty are more engaged to come here as well. What we're doing, we've got our ideals committee that are looking at all sorts of various ways to recruit a diverse resident pool. And that goes from having affinity groups speak to the applicants when they come, having the inclusion days that Dr. Rodriguez's office and my own have sponsored. And then even the departmental level, I think there's quite a lot that individual departments can do. When I was PD in anesthesia, and I know that they're continuing to do that since I've moved on, is actually go to historically Black medical colleges that are statistically more likely to have underrepresented medical students, and actively recruit them to your department. When you sit down with these young docs and explain what you're doing and why you're doing it and why they need to come and hang out in Utah for a few years, they are incredibly receptive and very, very happy to chat with you and offer their concerns and their hesitations that you can address, or hopefully to their satisfaction. And then you hopefully get a whole bunch of diverse applicants to your program, and that is how you recruit more people. It's not that you don't specifically target individuals, you increase the diversity of your pool, and then that it kind of takes care of itself. And I got to tell you, this season, at an institutional level, we're still crunching the numbers, but we've done very well from a diversity perspective. And I think it's because a lot of people are doing this kind of stuff. I don't want to take any more time. Happy to talk offline, Lucas. Thanks for the question.
Thank you, Dr. Harris. I think it's really important to recognize that Zoom actually has been a boon for our diversity efforts and not a bust. And I would encourage y'all to actually engage Dr. Cariello and Dr. Kimiu's office. Dr. Kimiu had been making calls to underrepresented candidates from multiple residency programs, and that has proven to have a positive outcome. So it says here, we've talked about salary data and sexist jokes, but what can you comment on the influence of sex stereotyping in the workplace and what is or can be done to address this? Now, this is a far more serious comment than sexist jokes. And I think that one of the things that we have to do is look at internally, right? This is a time for introspection. And we have to challenge how we see things. And then we have to actually work on changing ourselves. Now, Dr. Hightower talked about the implicit bias testing, and maybe you can continue on that thought, Dr. Hightower.
Yes, so there, and somebody put it in the chat, the link to the Harvard implicit bias test. But that really is the beginnings of introspection. We're all on a spectrum when it comes to our journey on awareness of disparities, on injustice when it comes to power, privilege, and whether it's race, sex, LGBTQ, age. The nice thing about the Harvard implicit bias test is it's multiple different. It's not just race and ethnicity, and but even they have one on age. You know, what is your initial perception biases around age? And it begins the journey of introspection. See where you are from a baseline, and then from that, be able to explore either individually or with groups. And many of our leadership in healthcare IT, we've actually all done this. All of like Travis Gregory and Jim Livingston. You know, IT folks. If IT folks can do the implicit bias test and be surprised and have a conversation about race, ethnicity, and how our role in healthcare IT, then so can surgeons, so can providers, so can nurses, so can administrators. And again, we had a nice, we talked about psychological safety and the importance of being able to discuss this together voluntarily and explore where to go from there. I'd say the output was not only individual journeys, but incredible creativity. So a lot of the work that you saw on on approaches to disparities in the COVID vaccine effort, our IT teams developed some pretty cool automated systems to actually reverse some of the biases that are out there. So they actually automated 2x, if not higher, outreach to our underrepresented minority populations. They coded that in, and they came up with these ideas mostly because of having gone down this journey and said, okay, we want to be anti-racist, we want to be anti-bias. The reason why we were able to develop the algorithm or the way to measure disparities based on race, ethnicity, demographics so quickly is because the team was hungry for things to do that would be anti-racist, anti-bias within their work. And so part of this is starting the journey, but it sort of sparks, it's a little spark that then can catalyze further action and empowerment at work.
Thank you, Dr. Hightower. I love that idea of spark, right? Because really it's a spark that has to develop into a wildfire. Sexism and racism are pervasive in our institution. And I think that the pervasiveness of these two things really require us to actually work in every single place that we can to eliminate them. So when anti-sexism and anti-racism become pervasive, I think we will have gotten to a new place. Now it's 8 o'clock and there's still some great questions on the chat. I can stay on for a little while longer, but I want to respect the people's time because Dr. Carroll made it clear to me that the ORs are opening at 8. So, Dr. Carroll, how do you want to proceed from now?
Like, first of all, I want to thank both of you so much for being here and giving us such thought-provoking fodder to really mull over as a group, and I really appreciate that. I guess if you can stay and answer some chats, that would be wonderful, but I myself have to go. So, but I truly, truly appreciate all of you. And I want to thank again, not just the folks who were presenting today, but all the people who made this possible. We had admin support in every single department who did trial runs of this. We got extra Zoom licensure so we could have so many people. And that was a ton of work by our admin staff. And I really want to recognize their work for making this happen and thank them.
And thank you. So we can continue answering these questions. We talked about sex stereotyping. The next question was about gender identities and do we have formal training and resources for that? And our office does have formal training and resources for inclusion and equity for the spectrum of gender identities. And we work closely with the LGBT Resource Center as well. I can get those resources to you, just send me an email. Jen Wilson in our office has put those together. The next one, Dr. Hightower, you want to take it? Sometimes being anti-sexist and anti-racist has consequences in itself. How can institutions like the U of U combat this?
Oh, that's a great question. So yes, it does have consequences, and sometimes it's just the psychological toll. This isn't exactly the low stress work. And I think one thing that the U of U does really well is provide resources through the Wellness Center, at the very least, to increase our resilience, to maintain our consistency of purpose. And that's really the biggest challenge over time, is consistency of purpose. For many of us that have been part of this journey for a long time, we've maintained sort of the practice of consistency of purpose, but for those that are newer, it'll wax and wane, and that's really the hard part. But for the U, I think does a good job of making resources available, and this is relatively, I wouldn't say it's like 100% psychologically safe, but it is relatively psychologically safe. Dr. Caldwell, I think you had a question, or you wanted to say something.
No, I just wanted to thank you very much for the presentation. And I think these issues need to be addressed head on with all the departments of surgery. And I think it was very informative, and I look forward to working with you both. Thank you.
Thank you. Well, I've got to hop off. Thank you so much,
Likewise.
everyone. And I'm always happy to answer questions.
Well, thank you, Dr. Hightower. I could probably stay on for another 5 minutes. There's still a lot of questions, and it's up to the group if you want to address them now, or if we want to just try and take it offline. I know that a lot of people have to go, so maybe I will copy the chat and try and answer these questions by email, if that works for y'all. Oh, I can't copy the chat. That stinks. All right, so I will try to answer some of these questions. I think there's only one left, and that is, how do you differentiate between systemic racism and sexism and individual choice? For example, obstetrics is nearly 95% female, but it's widely considered not to be sexist because men don't choose that specialty. Perhaps a field like neurosurgery is chosen more frequently by males than females. Do we need to redouble our efforts to even out those two specialties to make them more 50% male and 50% female? So that's an interesting question. And I think the answer lies in what medicine has traditionally been. And medicine has traditionally been male dominated. And so the fact that OBGYN has a lot of women in it is actually progress in my book. And even if it ends up to be a 90% women specialty, because that's what women choose, I don't think we have to go working to make that more even. I think we have to do the work to make it more even, however, in the male-dominated spaces. My vision is the same as Ruth Bader Ginsburg's. You know, the late, I want to call her Dr. Ginsburg, but you know, she's a lawyer. But she said, she was quoted, they asked her, when would she be satisfied with the gender diversity on the Supreme Court? And she said, when there's 9 of us. And I think that's how we look at our medical specialties. We don't worry about evening it out. We worry about things when it's 100% women. Then we start looking at interventions to increase men. Now's not the time. So there's some great links here to Molly Carnes's work on reducing bias in academic medicine. And on that one, I will close up. Thank you for being here. I'm leaving this room inspired. So looking forward to working closely with all y'all. And onward, we're with you in this effort. Have a great day.
Thank you so much, Dr. Rodriguez.
Anytime.